From the campus of the University of Kentucky, you're listening to Behind the Blue. I'm Cody Kaiser with UK Strategic Communications.
My sense is patients appreciate honest, candid answers as opposed to sugar-coated, rosy pictures of what transplant life is like, because it is complicated and it takes a while. The convalescent period takes a while to traverse. And, for the rest of their lives, they're not the same as they were before transplant because their immune systems are weak. So they have to approach things differently and change some of the things that they can do. And that requires patients to be aware of that. I had a nurse one time tell me, lung transplant's the only thing a good lawyer can't get you out of.
That's Dr. Edward Cantu, the new director of the UK HealthCare Lung Transplantation Program and the Thoracic Surgery Division. After years at Columbia, Duke, and the University of Pennsylvania, he's now leading UK's efforts to improve access to advanced lung care in a state with one of the highest burdens of lung disease in the country. On this episode of Behind the Blue, Dr. Cantu talks about what makes lung transplantation both incredibly complex and potentially life-changing, how advancements in surgical techniques and anti-rejection medications are reshaping outcomes, and why the unique challenges facing Kentucky and Appalachia demand a more connected and collaborative approach to lung health. Dr. Cantu also shares insights into solitary pulmonary nodules, UK's plans for program expansion, and what better breathing could mean for patients and families across the Commonwealth. Dr. Edward Cantu, thank you so much for taking the time to talk with us.
Thank you for having me. It's my pleasure to be here.
So for listeners getting to know you for the first time, and I think that's most people, since you're new here, can you walk us a little bit through your background and maybe talk a little bit about what led you into thoracic surgery?
Sure. Well, I grew up in Texas, San Antonio, home of the 5-time champion NBA Spurs, who I'm a big fan. And I was always sort of fascinated about processes within the human body. I grew up in a family of farmers and ranchers, and so I was always a little bit of an oddball. And I, wanted to give back to my community, and there was a lot of smokers where I grew up, and, it was something that I was around, and I saw a lot of the complications of that. My father died of lung cancer. And, as I grew up, I always wanted to be the best. So I went to college at Harvard and medical school at Columbia and ended up going to Duke for my surgical training. While I was there, I learned a lot about complications related to smoking, and I learned a lot about lung transplant. It became something that I found incredibly interesting, and it was something that I felt I could have a direct impact in people's lives. So, someone who's breathless one day, the next day is no longer breathless. And that to me was miraculous. So that started my journey into transplant. And my first job was at the University of Pennsylvania, where I was at for the last 16 years. And as that experience grew, kind of missed being south and an opportunity arose where I could come to the University of Kentucky. And it was something that I jumped at the opportunity because I could be around folks that I could relate to. And it gave me, a feeling of almost coming home.
So your training path really put you in some major medical environments, from Columbia to Duke. What do you take away from that as far as how that shapes your approach to lung disease and complex surgery? Because I'm sure in those places you're seeing some really complicated cases.
Yeah. So I kind of look at it this way, right? So it's kind of like technical training. So it's like learning from a master mechanic. So you get all of the experience that they've taken a lifetime to accumulate. You can take all the good from that and then, transplant it elsewhere. So for me, that experience was all about learning how to take care of complex lung disease and gaining the experience and the tools necessary to be able to practice that everywhere. And, it's not always good. These large academic centers have a lot of positives, but they also have a lot of negatives. And, it comes with the territory. Everywhere is got their challenges. And, so I learned from that experience, both positives and the negatives. And so I'm hoping here in Kentucky, I can take that experience and hopefully create an environment where we can treat complex lung disease at a level that can benefit all the patients in Kentucky.
Considering Pennsylvania and Kentucky, Appalachian communities, a lot of similarities there. As you settle into being here, is there anything that strikes you most about kind of the communities and the patients that UK HealthCare serves compared to maybe where you've been previously?
Yeah, absolutely. I think some of the challenges that we saw in Pennsylvania were that some patients just didn't have the means to come back to the hospital as often as we would like. So I think here, we have similar challenges. And this is something that I really want to work with our sister affiliates and other hospital and health systems to see if we can co-manage these patients together. I think that's something I want to make sure that all of your listeners understand. We're not here to take patients away from the communities. We want to be able to take care of those patients where they're at if we can safely. And the idea is to put in together a collaborative practice so that way every patient gets the best quality of care that they can. From my perspective, I get the sense that, usually those who are most challenged tend to be the patients who need the most needs or have the most needs. And if we do a good job of addressing those needs collaboratively with their healthcare teams at home, we can get the same or better results than patients that have means and can travel more.
I want to put a pin in this and come back to talking about this, but just to kind of get to some basics for listeners who may be new to this, how do you, and maybe in a sense, like when you're having that doctor-patient consultation and conversation, how do you explain what a lung transplant is and when that becomes the best treatment option for people?
Oh, that's a great question. So I kind of look at it as a process, right? So we talk a little bit about how, lung transplant's not a cure, it's a trade. We're trading one problem, which is their lung disease, for a different problem, which is a weakened immune system. So the body is always fighting off things that are not us. And it doesn't care if that not us is an organ that's keeping you alive. So in order to prevent rejection, which is the body's destroying the new transplanted organ, we have to weaken the immune system enough that organ isn't destroyed. The downside of that is it also makes the body's ability to fight off other infections less effective. It also increases the risk of cancers and other things. So I always start the conversation that way and make sure that patients understand there will be some new medicines they will have to take that will weaken their immune system for the rest of their lives. And then once we've discussed all the side effects of those medicines and the implications of that, we then talk a little bit about how I do the operation. And, the operation is technically complex, but simple to describe, right? I'm exposing three major structures, which is the bronchus, the airway, the pulmonary artery, and the pulmonary vein. I get control of those. I'll divide them, and I can remove your lung from your body. And then I can put back a new donated lung by sewing in the bronchus, the artery, and the vein. And that's pretty much the description that I would give. It's a little more complicated than that. I'll explain a little bit more, but essentially that's what it is. And then the next step we'll be talking about what is the hospital stay like. Most people think that you get a lung transplant the next day, you feel great. That is not the case. In fact, the next day after the breathing tube comes out is probably one of the hardest days of their lives because they're sort of learning how to breathe again. They're much weaker than they were before the transplant, and generally they're on more oxygen. So it is a challenge physically and mentally that I try to prepare patients for. I try to explain how that process is going to go. And then the next thing we talk about are the risks, right? And we talk about all those risks because in my experience, every single patient has at least one complication. The complication could be something minor, but they will have it. And if they know to expect it and they're prepared for it, it's usually a blip that then goes away and doesn't affect really how they do. And so preparing the patient and the family for those kinds of events better prepares them to deal with it post-transplant. After that conversation, we then have a conversation about where the organs come from. And, it's important to understand the different types of donors and donation. And we talk about the risks and benefits of those. And then once we've done that, we talk about how you make the decision to proceed with lung transplant. And that's sort of the last thing we do. And almost all patients will ask, well, should I go for a lung transplant? So my goal is to give the best length and quality of life possible for every patient. And so I explain that to them and we discuss, what is your quality of life now? What is your comfort with the risks? And then they'll make the decision whether or not to proceed for lung transplant or not. And, then there'll be a meeting afterwards and we decide if they're candidates or not. And so all of this is a conversation that goes back and forth that generally takes about an hour. And when the patients leave, they have a lot to talk about. And generally, I think that type of process works really well. And, my sense is patients appreciate honest, candid answers as opposed to sugar-coated rosy pictures of what transplant life is like, because it is complicated and it takes a while. The convalescent period takes a while to traverse. And, for the rest of their lives, they're not the same as they were before transplant because their immune systems are weak. So they have to approach things differently and change some of the things that they can do. And that requires patients to be aware of that. I had a nurse one time tell me, lung transplant's the only thing a good lawyer can't get you out of.
What diseases are we talking about or conditions that most commonly lead patients to this point where they need a transplant?
So there's 4 big categories. The first are obstructive lung diseases. This is like emphysema, bronchiectasis. There are pulmonary vascular disorders, most common being primary pulmonary hypertension. Then there are septic diseases like CF, although CF is now less likely to require transplant given the new drugs that have come online. And then the third group are restrictive lung diseases. And restrictive lung diseases are pretty common. So idiopathic pulmonary fibrosis, sometimes called interstitial lung diseases. This is where you have co-workers' pneumoconioses. You can have other types of diseases that are exposure related to mining or, working in battery factories like silicosis and things like that. So those are the main categories. The most common in Kentucky would be the restrictive lung diseases like interstitial lung diseases, IPF, and emphysema or COPD. And that's just given the exposure history of patients here in Kentucky, which has a very high, I think it's the highest in the United States for emphysema, and then one of the highest for exposures like occupational health exposures.
Recently, I had on Dr. Meyerson and Dr. Shaw to talk about our robotic lung scan and then, surgical, robotic surgery for nodules, lung disease, things like that. You've done extensive work with lung nodules, and Dr. Meyerson actually even mentioned that people here in Kentucky, we have a high rate of that just because of the very nature of it's in the soil, it's in the air. And so while those may not be anything that leads to anything cancerous, there's a large amount of that here in the state. Can you talk about kind of what those are and why they matter and kind of how they maybe influence like your treatment path with a patient?
Yeah, no, I think, given the region that we're in, there's exposures that cause a lot of solitary pulmonary nodules, right? And as far as background, in Kentucky, the number of people who have chronic lung disease is very high. In fact, I think the incidence of COPD in Kentucky makes it the highest disease burden state for that diagnosis. It's also one of the highest rates of solitary pulmonary nodules. And the downside is that of those solitary pulmonary nodules, we diagnosed cancers much later than other states. And part of that is something we're looking to address as part of the lung service line that we're putting together. Work with Dr. Meyerson and Dr. Shaw and other members of the Cancer Center to put together a system where we can identify these nodules much earlier and intervene on them before they become serious cancers. And so right now, I think Kentucky's ranked 47th in the U.S. for treatment of lung cancer. And mostly it's because the challenge of identifying them early enough. And I think, as I sort of mentioned earlier, what we want to do is collaborate with our affiliates in order to help patients be diagnosed sooner. Some of the initiatives that Dr. Meyerson and Dr. Shaw put together can allow for us to take a patient with a diagnosed nodule through the entire process in one anesthetic period, which is pretty remarkable when you think about it. So we could potentially take, diagnose, and treat a lung cancer all within one visit. So these are things that we're trying to ensure that people know about because this is not something that can easily be done elsewhere. And it can lead to some significant improvement in treatment paradigms within patients who have solitary pulmonary nodule. Now, I'm not saying that every single patient who has a solitary pulmonary nodule needs surgery or needs an intervention, because a large number of them, as you had mentioned, are infection related or are not at all cancerous. And so part of this is to also identify those nodules so that we can tell patients, don't worry about it. This particular nodule is not something will ever be cancer. It's not something you have to worry about. We just want you to know about it so that way when someone else sees it, they don't tell you, oh my God, this is a cancer. You will know about it. You will know that it's low risk, and it makes sure that you don't have to have an intervention when you don't need one. And so our goal is not only to, intervene when we need to, but also to educate patients so that way they can make sure that they don't have interventions that they don't need. Again, sort of as I mentioned with the lung transplant, we want to make sure we give the best quality and length of life. And, some of these procedures can affect the quality of life. So we want to make sure not every patient with a solitary pulmonary nodule ends up having a surgery or, radiation or something that could affect their quality of life. In these low-risk patients, if we can prevent them from having procedures they don't need, then that's better for them.
The process of a transplant surgery, the technology behind it, the method, that seems like, I'm sure that area has improved even in the last 10 years, 20 years, significantly as far as like technique and the ability to do this much more rapidly, things like that. Talk to me a little bit about these advancements and also like in the anti-rejection medication, because I know that it plays a big part of it as well. And so how has that have we seen the landscape change in the last, 15 to 20 years?
So the first successful lung transplant occurred in 1983. And from that period, the outcomes of lung transplant, if you look at every era, like every 10 years, the survival has increased. And in fact, now 1 year survivals 88% or better. That's fantastic for lung transplant, but it's still terrible compared to other solid organ transplants. And part of that is the lung is continuously being exposed to the outside. Every breath you take has the potential to expose the lung to a virus, bacteria, fungus. So your lung is actually a pretty potent immune organ, right? And so there have been improvements in the techniques of surgery. So we do them a little bit different now than we used to. There have been improvements in some of the medicines that we use. So initially, the when we first started doing lung transplant, we used azathioprine, cobalt irradiation, and steroids. And now we use different drugs. There's still a calcineurin inhibitor and an anti-synthase and steroid, but now they're much better than the drugs we used to use in the past. And so that allows us to better manage patients postoperatively. Now, more recently, new techniques to use organs that weren't usable in the past has come online. So new preservation techniques, new evaluation techniques. So, and what I'm talking about there is, it used to be we would take organs and put them in a saline solution with ice. Now we're evolving a little bit away from that, and the results have been preliminarily better. We've also developed systems where we can test organs out of the body and in the body of a decedent. And that allows us to make sure that the organ's going to function the way we expect it to. And that gives us the opportunity to look at organs that we wouldn't look at 20 years ago. So a lot of different things have been happening to improve outcomes and increase the number of transplants. In fact, last year we did 3,300 transplants, the highest we've ever done. And so I think as our experience continues to evolve and as we understand the transplant procedure a little better and donor evaluation a little better, we will be able to offer this life-saving therapy to more and more patients. Like, our goal is to be able to transplant anyone who's waiting. And one of the things I haven't mentioned, but has been something that I've looked into research-wise, and other organizations, individuals, and companies are looking into, are manufacturing organs and creating xenotransplant organs. So you might have heard of that, using pig organs for humans. Now, these are all still in the developmental stage, but imagine if we could have an organ available for every single patient that had the same outcome. And these would be humanized organs, with some genetic techniques that have become online in the last 10 years. So that way, no one dies waiting for organs. Like right now, 20% of those waiting for lungs will not get a transplant in time because there aren't enough organs. And that's with us being as aggressive as we can, looking at new donors, and doing everything in our power to prevent that. But that's still, to our shame, we haven't been able to prevent that. It's much better than it used to be, but it's still not zero. And the goal of every transplant center and transplant surgeon and pulmonologist in lung transplant is to be able to transplant all our patients. But unfortunately, they're just not enough.
Now, correct me if I'm wrong, the process here, is it different from, as far as like from a donor side of it, is it different from, say, like a kidney transplant or a liver transplant, in that you can give a kidney and still live your life? You can give part of your liver and still live your life. Is it possible to give a lung? And do you have that happen with a prevalence, or do most donors come from other situations?
Yeah. So you're mentioning living related or living donation. That doesn't happen so much anymore in lung transplant. There was a period of time where it was done, but in those situations, it's usually two parents to a child. Not very commonly done. I don't think it's been done in the United States since the early 90s. It's just dangerous. It's the only type of donation in lung that can actually result in 3 times the mortality. And so not really done to any significant degree in the United States or most of the world. I think maybe in Japan it's done. And part of that is due to some of the difficulties they have with organ donation due to some religious beliefs. But I think for the most part in the United States, it's not an option. We don't really do living related or not unrelated lung transplants, just because of the risk involved to all those who would participate. But you do mention, do we think about expanding the donor pool in other ways? And we have some of the things. So donation after circulatory death donors, that initially started in the 90s, and that's been increasing. In fact, the number of DCD, that's what we would call donation after circulatory death donors, DCD, and the easy way to think about it is heart dead donors, right? So the way the world defines death is through brain death and through heart death. And heart death, imagine, in those medical dramas where they show the flatlining, that's sort of what that is. So those patients, weren't very common until recently. And when I say weren't very common, less than 5%. And now the amount being used in the United States is slowly increasing. Now, the United States is behind other countries in that type of donor. Like Australia, I think, is the most sort of advanced in terms of using those types of donors. And I think it's anywhere between 40 and 50% of lung transplants in Australia. So for us, we're still around 10 to 15%. So there's still opportunity for growth in that vein. But, we have to make sure we do it intelligently and safely, and that we educate the public about it, because what we don't want to do is put anyone at risk. And we have a responsibility to the donor families and to those patients that we would transplant, to do everything in a way that preserves dignity in dying and preserves safety in the candidates who receive transplants.
I want to come back to some things we were talking about earlier, specifically about this region, Kentucky and Appalachia. We have some of the highest rates of chronic lung disease in this country, but we also have a lot of unique situations with just access to healthcare, things like that, from access to screening, smoking prevalence, occupational exposures. Talk to me a little bit about structural barriers and how they contribute, I guess, to poor lung health in these communities, and kind of what your outlook is as far as like how we approach, that type of stuff.
Well, I think some of the barriers are, you can think of them as, I guess the best way, like equipment. They may not have the equipment, or if they have the equipment, they may not have the technician. Or if they don't have the technician, they may not have the interpretation part. So you can think of every person with lung disease requiring a couple different components to work together for them to get the care they need, right? So they need someone to ID there's a problem. They need the equipment to facilitate that. And then they need a collaborative environment where they can make referrals to a treatment team. Not all parts of that are functional, and maybe there is all parts somewhere, but there may not be the capacity for the volume. And so then people have to wait. So there are a lot of challenges that are not expertise based. They may be due to capacity or, some kind of structural problem. And so I think one of the things that I want to do with the lung service line is understand these challenges that different health systems have within the state, and to reach out to them and provide support in what capacity is needed. So if they don't have the analytical components, then maybe we can set up a telehealth system so we can have a virtual clinic. If they have the expertise, but they don't have the operational part, which is the interventional component, then maybe we can have them send those patients to us, and then we can take care of it for them. So it's going to vary depending on the health system and the group that we're talking about specifically. And I apologize, I'm keeping this kind of vague, but it's because it's not the same for every group. And so the way I look at it, we need to divide it up into those components and then partner with these groups where they need the support that they need. And again, as I mentioned at the very beginning, we want to collaboratively care for these patients. The end goal is the same for us, and whatever health system we partner with is outstanding patient care, the best quality and quantity of life that we can provide. And I think we can do that better together than we can, in competition. So that would be how I would address that, those challenges that Kentucky has. And some of those challenges are similar to Pennsylvania, where I came from. And certainly some of that is very similar to how I grew up. So I grew up in rural Texas, though my older years I was in San Antonio. So yeah, I think when you think about how to implement a strategy that can improve the care of all patients, you need to think of it in those terms, like an analytical diagnostic and a sort of interventional therapeutic kind of arm. And so, those will be things that we'll work with other groups to try and improve operationally.
When we talk about our program, current state of it, how many lung transplants have we done at UK, or do you see us doing over the year?
So I think to date we've done over 500 transplants at UK. We don't have a target goal per year in terms of volume. It's all dependent on the number of referrals we get. So essentially, I think our volume goals are dependent on how many people we have on our list. So right now our list is really small. We're limited because the program is still growing. But I feel that with time, anywhere from 50 to 100 lung transplants a year is very doable. And I hesitate to give numbers because it then limits people's expectations. But we will do up to 200 a year as an aspirational goal by 10 years.
Do you know how many we have on the waiting list right now?
I think it's under 10. It was 6 the last time I looked. It's probably around that right now.
And then, how many could be, ballpark estimate, how many could be or potentially could be?
Well, I think we'll probably, once we're fully operational and fully staffed, I think we'll have between 50 and 60 on the list at any time. That would be my goal.
Well, kind of building off of that, UK HealthCare has announced plans to expand this program. So in taking that into consideration, kind of what does that expansion look like as far as clinically and geographically and maybe in terms of patient capacity? And kind of what does a strong, comprehensive lung transplant center need in terms of like infrastructure, staffing, multidisciplinary teamwork, things like that? Like you have the artist's brush, you paint that picture as you would build that out.
Yeah, I think so. The most important thing to understand is for all these processes to be successful, whether it's lung transplant or solitary pulmonary nodule, it's team-based, right? It's not an individual-based. So the way I would look at these things is, we need the whole team to work together. So there's the UK team, which is, the surgeons and the pulmonologists, but it's also the PCPs, the internists, the geriatricians. All of these components need to work together for us to take care of these patients. So some of our outreach will be reaching out to these providers who don't routinely deal with lung transplant patients and giving them the opportunity to collaborate with us, so that way those patients that they have that are breathless can be referred for lung transplant. So that requires outreach. So I'll be traveling to Eastern and Southern Kentucky actually a week from today, and reaching out to those centers to explain that process, to see where we can help. And then part of that is understanding what their needs are. So I think, for a successful program, it requires a lot of collaborative work. And again, once the treatment is done, let's say if the treatment is done at UK, we want to collaboratively work with that practice to take care of them long term. So some patients will require, long-term care and, will require, yearly or quarterly assessments, and having all that in place, making sure that that's occurring is something that we'll need to work with. So I think the hard part and the challenge is there are a lot of moving parts within a successful system, and navigating different electronic health record systems, navigating different processes, different work models. So maybe it's a nurse practitioner who runs a clinic, maybe it's who's supervised by a physician who's at 2 or 3 different hospitals. So there's a lot of challenges that we need to think about and think about how we can scale the support that's needed by those practices. So, again, I'm talking pretty generally, and it's because it's the specifics for each practice that we collaborate with to make this successful at UK is going to vary, and it's going to require slightly different support for different places. But it's generally, a system where we think about support in the diagnostic, support in the therapeutic, and then support in the follow-up. And, different places will need different support in different areas. And our goal will be to facilitate whatever is needed to shore up those needs. So that's how I look at it. And I apologize, I'm not more specific, but I don't have the magic bullet that will solve everything, unfortunately. And as you mentioned, Kentucky is a state with a significant disease burden in lung disease. And, I think even if we can get a 60% improvement, the number of people that would help is pretty incredible. I think the last time I looked at the health department's records in Kentucky, there were almost $500 million spent taking care of patients with lung disease. And despite that, 4,400 people dying every year. So I think we can do better. And I sincerely hope that our vision for UK to support other health systems and practices can make a dent in that number.
What changes for a patient and for their family when a transplant program is close enough and has enough of a network that patients no longer have to have extensive travel across a region for evaluation and follow-up care? And how much of a shift does that make?
Oh, absolutely. It has a huge impact, right? So if you live in Appalachia and you have to travel to UK, that may be a problem for you because maybe you don't have the means to get here. So we want to try to make it as easy for folks to get access to care as possible. And so we're going to start implementing systems. And again, this is stuff I will discuss with the executive leadership of different health systems to see, can we do some of this work up locally so that way the patients don't have to go very far? And then can we establish local care systems that will benefit patients, but also the regional centers, so that way it helps everybody, right? My goal is to change the patient experience in the sense that we want to be patient focused. Like where I came from, you couldn't get transplanted at that institution unless you came and had all your tests at that institution. And I know that was a barrier for some folks because some folks can't do that. And so, that's not something I want here at UK. And it's not something that the executive leadership at UK wants. And UK, which I'm happy to be a part of, is 100% on board with making transplant and lung care as accessible to the residents of Kentucky as possible. That is a refreshing change from some of the health systems I've had experience with before. And it's something that I think was a compelling reason to come, because it's not about, the numbers or the money. It's about, and every single meeting I have with the executive leadership is about the patient. How do we help more patients? How do we improve quality of care? And that to me is something that is really appealing. And as a patient advocate, that would be something that I think as a patient, I'd be happy to know that is how decisions are being made.
I feel like, too, the university, UK Healthcare and the university, we're also kind of uniquely situated in that transplant journeys are generally a long process, a long journey for a patient and for their family. And those support systems range from medical to non-medical as well. And there's a lot of things that I think about that factor in, not just in access to, a clinic or some kind of medical facility nearby, but also the support systems in place, for the day-to-day for those families. And so, I think that our work in research and service and all the different areas that UK touches on, I feel like it's a good place to be in a collaborative sense as far as like helping to address some of those, situations as well.
Absolutely. I'm talking about the clinical side, but there's the education side and there's the research side, right? So we are also mission driven to create the new leaders in the field who will take over when, they need to take care of me. So I just came back from an executive meeting just before this, and I was telling everyone that every person I have met at UK Healthcare has put patient care first, and it has grown to any challenge that has come. So, I did 2 transplants on a weekend. Initially, I was told, well, no one's done that, and they weren't like, no, you can't do this. They were kind of, let's figure out how we can do this. I had perfusionists who had never done transplants the way I do them and have done them for years. And we got through those growing pains together. I had CT anesthesiologists who, tried doing something that they've not done the way that I've done it. And we grew for that. And then I had surgical faculty who worked with me, and we all grew together. And I had scrub nurses who'd not done lung transplant ever, who rose to the occasion. And with that experience, I observed many different people from many different experiences rise to the occasion and provide the quality of care that is no different than any ivory tower in the East. And so I would say that I was not only impressed, but I was awed. And people, don't realize how important that is in a transplant program. So yeah, I have no doubt that UK will be top 10 education, research, and transplant center in the near future.
That speaks volumes. It's excellent to hear. Looking ahead, kind of putting a close to this, the landscape for UK Healthcare's lung transplant program, research, early detection, community partnerships, preventative care, all of that. When you package all that together, what do you want the landscape of that? What do you hope that it looks like over the next 10 years?
So my vision is that every person with lung disease has better living and better breathing. So, the goal is to have a system in place where the volume of patients that we see every year is more than doubled, that we can see a dent in the number of patients who die because of unrecognized solitary pulmonary nodules, or die, if we can bend the mortality curve for lung cancer, so that way we can improve and get out of the bottom 10 percentile and get into the top 10 percentile. I think we could see some dramatic improvement in the quality of life of patients suffering from lung disease. I think as one of the highest disease burden groups, we have the most opportunity to show the best improvement of any state in the country. And I think, having met the families who we've treated so far, all salt of the earth human beings who deserve better quality care. So my goal is in 10 years, our transplant program is internationally known for high quality, high volume, patient focused treatments, and our lung center is also known in that vein. So I want us to be the place where everyone wants to come to get treatment. I want us to be the center where all the innovations are tested. So that way every patient in Kentucky has every opportunity to join any clinical trial that's run in the United States. And then lastly, I would love to see us be the center where we train the future leaders in lung care. And so I think that's all in alignment with the executive group and the university, and it's in alignment with the department chairs for surgery and medicine, as well as the chiefs for pulmonary and thoracic surgery. So I think it's going to be a very interesting, exciting next few years, and I look forward to talking to you in 10 years and saying I'm retiring and the new leader is so-and-so.
Well, based on how you've laid it out, you do seem very optimistic about the work ahead and kind of what our future is shaping up to be.
Yeah, no, I like, as I mentioned, I think the quality of the people who work at UK is phenomenal. I think they care about their patients above all. And I think that the bones are here. We just need to put all the muscle together so that way, we can work well together. And I think once we establish that, the sky's the limit.
Last question. For someone dealing with advanced lung disease right now, either themselves or in their family, what's the most important thing you want them to hear?
Well, I want you to hear you're not alone, right? So we have a high quality team that's ready to help you get through this process. So the goal, again, is always the best length and quality of life possible, and we'll make that happen for you.
Excellent. Dr. Edward Cantu, thank you so much for your time. I really appreciate it. And thank you for, I don't feel like I felt like I understood what you were saying. You weren't talking over my head, so I appreciate it.
Well, thank you so much for having me. It was my pleasure to be here today.
Thanks for listening to Behind the Blue. Behind the Blue is a joint production of the University of Kentucky and UK HealthCare. For more stories about UK and UK healthcare, visit uknow.uky.edu.